Thank you for joining us for tonight's educational webinar on knee arthritis. Tonight's speaker is Dr. Craig Goubeaux, OrthoNeuro's new hip and knee reconstruction surgeon. Dr. Goubeaux is a fellowship-trained orthopedic surgeon specializing in hip and knee reconstruction. He completed his hip and knee reconstruction fellowship at Sinai Hospital at the Rubin Institute for Advanced Orthopedics in Baltimore, Maryland, and his orthopedic residency in Columbus at Ohio Health. Areas of special interest include anterior approach for hip arthroplasty, same-day surgery, rapid recovery protocol for joint replacement, and complex knee and hip arthroplasty revisions. Please type questions in the Q&A box below, and Dr. Goubeaux will answer the questions following his presentation. Dr. Goubeaux?
All right, let me share my screen here real quick. All right. All right. Hello, everyone. As she said, I'm Craig Goubeaux. I'm one of the new orthopedic surgeons here with OrthoNeuro. I just completed my fellowship in hip and knee reconstruction out in Baltimore. So today I'll be giving a talk on knee arthritis, kind of what it is, some of the signs and symptoms of it, and what we can do to kind of get you back to doing what you want to do. So first off, a little bit about me, just to introduce myself. I grew up in a suburb outside of Dayton, Ohio called Springboro. I then went on to play baseball at Youngstown State University. Went and completed my bachelor's degree there in industrial and systems engineering. Then decided I wanted to go on to medical school. I was accepted to Ohio University down in Athens, Ohio. I also, at the time, completed my master's in biomedical engineering while I was there through a dual degree program, which was it was very beneficial, I think, for my future. And then I applied for residency and was accepted to the Ohio Health Doctors Hospital orthopedic surgery residency, which I did for 5 years. And then this past year, I was in Baltimore at Sinai Hospital at the Rubin Institute for Advanced Orthopedics. That's the hospital down there in the bottom. And just specialized in hip and knee reconstruction, which is what I plan to do here in the future. And then lastly there on the right, that's my family, my wife. I have two boys and then also a newly 1-year-old daughter. So getting on to the talk. So just kind of setting the groundwork. This is usually the complaints I get from people in the office is, can't participate in activities that you usually enjoy doing because your joints are hurting you. You kind of find yourself taking the elevator instead of the stairs because it's just more convenient and it's too painful to go up and down stairs. You're trying to find a parking spot, circling those parking lots to try to get as close as possible to the entrance instead of being able to walk into the store and kind of feel like you're, sitting on the sideline instead of in the prime of your life in the game, kind of enjoying the things that you want to be able to do. So just starting off with kind of the basics of the knee. This is what a normal knee looks like on the left there. You have your thigh bone or your femur, and then below that you have your shin bone or your tibia. In between, you see the shiny kind of bluish hue white cartilage that lines all of your joints. It's nice and smooth at birth and kind of helps your joints glide smoothly. And then you have your meniscus in between, where you have one on the inside, which is the medial one. You have one on the outside, which is the lateral one. They are kind of the shock absorbers of your knee to kind of help give it some cushion when you're doing walking or other impact activities. You also have some ligaments in there. There's 4 major ligaments in the knee as well. And then, looking at the right side of the screen, these are kind of what normal knee x-rays look like. This is the first thing that we'll get when you come into the office. It's kind of the bread and butter and gives us a lot of information. And like I tell patients, we can't see cartilage or the meniscus or the ligaments on x-rays, but x-rays still do give us a lot of information. So looking at the right side, the left picture is the femur bone on the top, the tibia bone on the bottom with your fibula, that small skinny one on the outside of that. And then next to that image, there's a lateral view, which is looking at your knee from the side. Again, you can see your kneecap a little better in that picture. That's that kind of floating bone on the front of the knee. And then that bottom x-ray, that is called a sunrise view, where we're looking at your kneecap joint. So it's called the sunrise because it's like your kneecap is coming up over the sunrise of your femur bone. So what is arthritis? So arthritis is um, inflammation of the joint. The inflammation has, so all the cartilage that covers your joint has started to deteriorate, and that can be from a multitude of factors. And it's an inflammatory response. So your body's trying to heal the cartilage that has been damaged for whatever reason. This leads to pain and stiffness and a bunch of other things that patients describe. But ultimately, it's a progressive degenerative process. So it is a process that will continue to get worse. There is currently nothing that we can do to put the cartilage back on a joint or regrow the cartilage. I know there is a lot of talk out there about some things that can do that, but nothing has been specifically proven to regrow cartilage. So arthritis, unfortunately, does tend to get worse over time. Ultimately, the rate at which it progresses, we cannot predict. I wish we had a crystal ball that could say, in 5 years it'll be at this point, but everybody's progresses at a different rate. And then ultimately, you hear people say they have bone on bone arthritis, which is when you get so much cartilage wear that there is no more cartilage left in your knee. The meniscus or the shock absorbers have worn out, and then the bones are touching each other, which is extremely painful. Here's kind of just different stages of arthritis. So starting on the left, this is kind of the way that we grade it as orthopedic surgeons. On the left is a normal knee where you have nice space in between. You see your femur bone and then your tibia bone. There's a nice black, almost like seagull looking black space in between the joints. And that tells us that there is a good space of cartilage and the meniscus kind of buffering the joints. And then you can see as you progress from left to right, the joint specifically on the inside of the knee starts to get closer and closer, and you start to see little bone spurs forming. So as the bones get closer and closer, we know that the cartilage and the shock absorbers have started to wear out. So the bones are starting to get closer and closer to that bone on bone arthritis. And then the bone spurs are a result of your body trying to basically just kind of stiffen up the joint and lay down bone to kind of make it so that it's not as unstable and painful. And then here's just kind of looking at a side view and then also that sunrise view. These are the typical images that we get in clinic. Looking at the side, again, you can see there's some big bone spurs on the femur and the back of the knee. There's some bone spurs on the patella or your kneecap. The joints are close together. And then again, on the sunrise view, pretty much the kneecap is riding bone on bone with the groove of your femur. So prevalence of knee arthritis, it's pretty common. 365 million cases worldwide, and it is the most commonly affected joint, followed by the hip and the hand. There were approximately 790,000 knee replacements performed in the United States in 2022. So a lot of people getting knee replacements for arthritis, but that's not the only thing that can be done for it. And this will only continue to increase as more people live longer. The average age in the United States is increasing, and the baby boomer area is getting older into that age range of when we typically see knee arthritis and knee replacements happening. So, symptoms of knee arthritis, big one is pain. You'll get inflammation or irritation. You get swelling. Swelling can come and go. Your knee can be worse at the end of the day and then go down in the morning. Worse with certain activities. You can have some people describe it as a dull ache, like a toothache, or some people describe it as a sharp stabbing pain. Sometimes you can feel that on the inside of your knee. Sometimes when you take a step or going upstairs. Usually it flares with activity because your knee is already inflamed and then you're kind of putting more stress on it and stressing it out. And then it can be worse at the end of the day, or a lot of people say it's difficult to sleep because they just can't get comfortable and they've been on their legs all day. Um, stiffness is another common one. You get loss of motion. So a lot of people will get flexion contractures where they can't fully extend their knee just because it's painful. And then their knee starts to get stiffer and stiffer over time just because it hurts to get your knee fully extended. It may be worse in the morning because you've rested it all night and kind of stiffened it up. And then once you get out of bed, it'll take you a couple steps to kind of get going and get it moving because now this smooth joint surface is gone. You don't have that nice smooth cartilage. You kind of have some bumps in the cartilage or some dings in it that don't let it glide as smoothly. Um, and as I alluded to, some people will get some grinding and clicking or popping, kind of like these rusty, worn out gears. You get it just doesn't glide as smoothly as they used to when they were first made. Some people will describe it as weakness, or they have a giving way or kind of a lack of confidence because their knee just it doesn't feel as stable as it once was. So it'll kind of, a lot of people say going up and down stairs or on uneven surfaces, they just don't feel confident with it. They'll use a cane or a walker because they feel like their knee, at any time they could get a jolt of pain and they could, have a fall, which we don't want. Um, and also, kind of the way that my mentor and fellowship kind of described arthritis and the symptoms of it is think of it like the tread on your tires. When you buy a new set of tires for your car, the tread is nice, you got good traction, you don't have to worry about it. But as you start to use them more, you hit a few potholes around town, you drive 80,000 miles on them, that tread starts to wear out. And, you can try to put air in your tire to kind of boost up the tire to give you a little more stability, feel a little more confident with it. But ultimately, you have bad tread, and that's the problem. Is the same thing with your joints when you get bad tread on your joints or bad cartilage. You start to not trust it as much. It hurts. You don't want to drive in certain weather. You don't want to go out in certain weather because you just don't trust it. So moving on to some of the risk factors. Big ones are injury or trauma. So if you've had a previous knee injury in the past, whether it be, an ACL from skiing, we see that a lot, or other activities, soccer or basketball, an ACL tear, something like that, or a tibial plateau fracture is another one, kind of pictured here on the right. That's where you have an injury to the tibial joint surface, and now you've disrupted that joint, and trying to get it fixed back anatomically is difficult. We try to do that as best we can as orthopedic surgeons, but sometimes the bone just gets too compressed and affects the joint too much that down the road it just leads to arthritis sooner. Obesity is a big one. This is one that obviously is at the forefront of everybody's head. There's a lot of increased obesity. With that, it increases the pressure on all of your joints because you're just putting more weight through all your joints and stressing them more. And I'll have a slide about that here in a minute, kind of laying out, how that impacts your knee. And family history is another big one. Um, if grandma or grandpa had knee arthritis in the past, they probably passed it down to you. When it affects you, again, we don't have a crystal ball. I wish we could, but everybody is a little different. But that is also a big factor. And there's other factors too. There's inflammatory diseases like rheumatoid and stuff like that. But these are the main ones. So moving on to treatment for arthritis. Really, it depends on the severity of it. It depends how much it's affecting your activities and how much you want to do. And we aim it at the stiffness, the pain, and the inflammation response. And really, it's symptom management and trying to alter your activities and different things that we can do to try to get you to be able to do the things you want to be able to do. And then, we can I'll talk about operative and then non-operative management, always starting with the non-operative management first. So non-operative management, this consists of medications, also some exercise, some physical therapy, possibly some bracing. I'll show some different braces. Injections are a big part of it, weight loss, as I discussed previously, and then activity modification. So first off, medications. A nice, safe medication that you can get over the counter is Tylenol. There's been multiple meta-analyses showing that it's often as effective as NSAIDs with less side effects. But then not everybody Tylenol works for. So the next line of treatment would be an NSAID or anti-inflammatory, such as Advil, Motrin. Those are typical ones you can get over the counter. There's Celebrex, Mobic, Naproxen, or Naproxen. Those are the typical ones that we would prescribe in the office. They're just a little more high-powered anti-inflammation, but they do have some side effects, so you just have to be cognizant of that, and I discuss that in the office. There's also some topical medications. These don't have systemic side effects, so they're also good ones to try as well. Voltaren is one that just recently was a prescription, but it's now over the counter. It's that typical orange and gray tube that you can see now at any Walgreens, CVS, or pharmacy. It's a good one because you can use it 3 to 4 times a day. You rub it in the affected area. It can be used for multiple different things, and it really doesn't have much side effects. And then there's a lot of talks about natural medications and herbal remedies. These are just some of them that I have listed here that we get asked about commonly. Really, all these are aimed at trying to decrease inflammation. So arthritis is an inflammatory process. So if you can decrease inflammation throughout your whole body, the thought is that that would help with decreasing arthritis. Um, and here I just have put in these are some of the clinical practice guidelines that the American Academy of Orthopedic Surgeons puts out. They do it every couple of years. They do it for the most common orthopedic injuries or pathologies that we see. So I've put in here their recommendations. These were in 2021, I believe, as the most up-to-date ones. Where they go through, they look at all the literature out there, they kind of summarize it all, and they give their recommendations on what the peer-reviewed literature is saying about different treatment modalities of how to treat different disease processes. So if you look at oral acetaminophen, so this would be Tylenol, it's a strong recommendation to help improve pain and function in the treatment of knee osteoarthritis. So it's a good first-line medication to try. Then moving on to NSAIDs, these are also a strong recommendation to help improve pain and function in the treatment of knee arthritis. Topical treatments, another strong recommendation. So that's that Voltaren gel or any type of like Bengay or Icy Hot. Um, and then this is the oral dietary supplements. These are the ones that I had listed for, turmeric, ginger, glucosamine, chondroitin, vitamin D, that kind of thing. Um, they are, it says the strength of recommendation is limited. So there's not a lot of good high powered studies out there saying that these have a significant impact. As you can see, it says evidence is inconsistent and limited, and additional research clarifying the efficacy of each supplement is needed. So these are supplements that I don't think they hurt taking, but I don't know that they do a whole lot. A lot of patients do say that they feel better after taking them. So typically, what you can do is try taking them for a month or two and see how you feel, and then stop taking them, and then see how you feel. And then you can kind of compare it and be like, I've had a pretty good last month or two while I was taking that, but the last 2 weeks since I've been off of it, my knee's been bothering me a little more. So that's a good way to tell and kind of do your own tests to see if it does seem to help you. And then people do ask about narcotics or tramadol, which is kind of another lower potent narcotic. This says strong recommendation, but you have to read it carefully. It says results in increased significant adverse events and are not effective at improving pain and function for treatment of osteoarthritis of the knee. So there are more negatives than positives for prescribing oral narcotics for the treatment of arthritis. So really, in order to prescribe these, you have to be a pain management doctor and have a special license for this. So I do not prescribe these for patients unless they have had surgery. Um, and then moving on to exercise or physical therapy, the main point of this is trying to stay active for some stretching to keep the joints limber and kind of just training your muscles on the correct kind of force vector, the correct gait pattern, and everything like that to kind of take load off of the joints when we can. Good exercises or physical therapy regimens. Water aerobics is a great one because when you're in the water, it takes pressure off of your joints. And you can do a lot of different activities in there. It's a high resistance exercises. And then also other big ones, like if you're going to the gym, the elliptical is great. A recumbent bike is great because you're not putting a lot of stress or force through the knee. Um, they have done studies on treadmills, and does that lead to increased rates of arthritis? And actually there's studies that shown that marathon runners do not have any increased rate in their arthritis compared to the general population. But if you do have arthritis, running on a treadmill may cause more inflammation in your joint and may cause you to have more pain. So it may not lead to further arthritis, but it may aggravate your arthritis if you already have it present. And then this is my mentor from fellowship, Dr. James Nace. He was my fellowship director, and he had a lot of great sayings. This was his big one that he told patients all the time. So arthritis being a progressive degenerative condition, we have modalities to treat you acutely, and we have modalities to treat you long term. So what is the long term plan? The long term plan is to stay light. So that is, weight loss, get the weight down, so less stress across the joints. Stay limber, so stretching and staying limber and being able to do all those exercises. Doing low impact activities like I just discussed, doing water aerobics, swimming, treadmill, biking. And ultimately, this is his classic coin saying is to lower the load across the limb or your leg for a lifelong of living. So basically, trying to do all of these things to decrease the stress across your joints so that you can have a lifelong full of living and doing the things that you want to do. And then here again is some clinical practice guideline recommendations. So supervised exercise, this would be, going to an exercise class, and just kind of having an instructor kind of walk you through things. Strong recommendation for that over doing nothing. Neuromuscular training. So this would be something that you would do like if you go to physical therapy and they kind of help you with your gait pattern and just kind of how to, walk appropriately or do exercises appropriately. Again, a moderate recommendation for that. And then self-management. So you going home and doing some exercises on your own gets a strong recommendation for improving pain and function with knee arthritis. So we want you to stay active. Sometimes activity does aggravate arthritis, but we still want you to stay active and do the things you want to be able to do. And there are other things that we can do to kind of help supplement the pain that you're having to help you to be able to stay active. Here are some bracing options as well. There's multiple different options of braces. I've put the main ones that I like up here, and we kind of do it based on your symptoms. Uh, the main focus of these is to kind of help with stability and give you a little bit of peace of mind. Some people really like the braces, some people do not like the braces. Um, some of them are big and bulky and they don't fit right, they fall down. So we have a very good staff of durable medical equipment staff that can kind of help fit you for these in the office and see, do you like this one? Does it fit better? And kind of show you exactly how to put it on, or maybe this one is a better option for you. Specifically, the one on the top, that one is called a medial unloader brace. So what that does is the picture on the left is demonstrating that you have arthritis and pain on the inside of your knee. So what this brace does is it puts pressure on the outside of your knee with the idea that it will kind of prop open the joint. So it kind of springs it open and takes the pressure off of those two bones touching each other. The medial side of the knee is where we see most of the arthritis, so that's typically what this one is for. The bottom left is just any type of like neoprene knee sleeve that you can get off of Amazon or Walgreens. There's like a copper fit sleeve. It's just more of a compressive brace to kind of give you some feeling of stability. Sometimes people like the feeling of compression on the knee. And then the one on the bottom right, that one's called a patella stabilizer brace. This is good for people that have more of patellofemoral symptoms, which would be, going up and down stairs, getting in and out of a car, getting in and out of deep chairs or off a toilet. So that's a good one for that one. But all of them can be used. It's just which one do you like and kind of testing them out. And then here again, another clinical practice guideline, bracing gets a moderate recommendation for improving function, pain, and quality of life with knee arthritis. And then again, broaching the topic of weight loss. Not only will weight loss help with the pain that you're having through your knee, your hip, your ankles, um, also in the future, if you choose, ultimately fail non-operative management and choose to progress with a knee replacement, it does help significantly decrease complications and help with your recovery post-operatively. So it's multifactorial. So if you look here, the force across your knee is 2 to 3 times your body weight. So if the average person takes 2,000 steps a day, which I would recommend more, but we'll say 2,000. If you are 33 pounds overweight, that's an extra 100 pounds on each knee per step. So if you have 100 extra pounds per step with 2,000 steps per day, divided by a ton, that's 100 extra tons on each knee per day. So extra weight can have a dramatic effect on your knee arthritis. So losing that weight is only going to be exponentially beneficial for you. And again, sustained weight loss again is recommended to improve pain and function in overweight and obese individuals for knee arthritis with a moderate recommendation. And then people will ask about alternative treatments, so I threw these in as well. Acupuncture is one, massage or laser treatment has kind of been gaining some traction now. These all have limited recommendations. Again, the literature just isn't robust enough to support them. Um, I don't see that they can cause any real harm. And if you feel like they do help you, then absolutely go ahead and I think it's worth trying. You never know until you try it. So it's always an option, but not something that I typically prescribe or recommend. And then moving on to injections. So these are a big part of treating arthritis. I know some people get very nervous about injections, which rightfully so. Nobody wants to get stuck with a needle. But the main ones that we use, a corticosteroid. The myth about it's a big needle, and I've heard horror stories about it. It's I guess you just have to see it. It's the same needle that we use for every other injection. Um, and it goes in the same spot. But some people have had bad experiences, so I understand. The point of this injection is really just it decreases inflammation. So there's a numbing medication in there and also a steroid in there. The numbing medication helps with pain. The steroid helps with inflammation, which in effect helps with pain. Which is what arthritis is an inflammatory process. This doesn't put any cartilage back on the knee. It is really a band-aid, and it is really just a temporary fix, but it's trying to manage your symptoms ultimately as long as we can non-operatively. You can get you can get them as soon as every 3 months. So you cannot get them sooner than 3 months. Um, but we do have patients that come in every 3 months, get their injections, and they go on their way and they love them. So usually I'll tell patients I'll give them to you and then say, just call me when you need me. Some people they last 6 months, some people they last a year. I've seen patients that come in every 2 years. So it's variable and there's really no way to predict what kind of relief you're going to get from them. You do have to if you do have diabetes, that is one thing to be cognizant of. It can increase your blood sugars slightly for a couple days after the injection. So typically if you have diabetes, and your blood sugars are not greatly controlled, and you want 2 injections, we'll usually do one and then do the next one the following week once it doesn't have a ton of systemic absorption, but 2 can be a little too much in one day. And then moving on to the viscose supplementation, these are the typical gel injections that you hear about. I put one down there on the bottom. That's Monovisc. There's Synvisc. There's Orthovisc. There's Durolane. There's the Suparts. There's a bunch of different names for them. It's just different company names. So the thought process behind these, it makes sense. It's like, well, my car is running out of oil and needs an oil change, and because the gears are getting all sticky, and I need it to glide smoother. So why can't you just change the oil? Why can't you just inject some basically visco or a gel in my knee and make it glide smoother? It makes sense. Um, but they're just not as effective as we would like them to be for whatever reason. The point is to restore the hyaluronic acid, which is a compound in your knee that your body naturally produces to kind of help try to repair the cartilage. And also it has some anti-inflammatory and analgesic effects to kind of help with pain and inflammation. These do require insurance approval, so you can't come in and see me in the office one day and get them that day. We typically have to submit it to your insurance, get approval, and then we can call you back when that's approved. They're about 50% effective. So it is kind of a coin flip. Some people say, you know what, 50%, that's great. I got a 50% chance, glass half full, that this is going to work. Other people are like 50%, man, I don't like those odds. I don't think that I want to try that. So it's up to you if you want to try it. For people that do get relief from them, they typically do get longer relief than the steroid injections. So anywhere from 6 months to a year more routinely than 3 to 6 months for the steroid injections. And then I did throw in some PRP or stem cells. I know those are kind of a hot topic right now as well. So basically what it is it takes your own blood, you spin it down to get the good healing factors, and inject that into the joint. And the thought is that it would kind of help repair or maybe regrow the cartilage. That has not been proven yet. There are multiple different treatment regimens, so everywhere you go is a little different. Some people do one injection, some people say you need a series of 3 or 5. So the studies out there are not great on the PRP injections. Also, they are expensive and they are out of pocket because they're not covered by insurance because they're not FDA approved yet. So I do not do them. There are people that do them. It is something to try if you want, if you have the money to try it. So again, here's kind of the recommendations from the American Academy of Orthopedic Surgeons. The hyaluronic acid injections, there's a moderate recommendation that they're not recommended for routine use in the treatment of symptomatic arthritis. So I think routine use is the key word there. Typically, I will start with the steroid injections. So this, as you can see here, has a moderate recommendation that it can provide short-term relief for patients with symptomatic arthritis. So the corticosteroid injections, they are tried and true, and they usually work pretty well for patients. If they start to wear off or they don't work, then I think the gel injection or the hyaluronic acid injection is a good option to try. But getting them routinely, I don't know that it really hasn't panned out in the literature that they are great for routine injections. And then down there at the bottom, PRP or stem cells, it may reduce pain and improve function in patients with symptomatic arthritis. Limited evidence. So like I said, we still just don't have the studies that support routine use of PRP, and hence why it really hasn't been approved by the FDA. And then, lastly, operative management. So for those patients that have tried everything operatively, or non-operatively, the medicines, the injections, the bracing, the therapy, the exercises, and they just can't get over the pain. They still want to be active and do the things they want to be able to do. I know pickleball is big now, especially people want to get back to their pickleball. So I understand. Um, so operative management, typically this is the last resort. You never need to have surgery. I'll never tell you that you need to have a knee replacement now. You tell me when your knee hurts you enough that you want to have surgery. And I just give you the information. I tell you you are a candidate for a knee replacement, but I will never say you need to have a knee surgery. And it's different for different individuals. I see patients that have terrible arthritis, and you're like, how in the world are you walking? And they say, you know what, my knee doesn't really hurt me that bad. It's my hip that's killing me. So, and there's other patients that they don't have as much arthritis and their knee is killing them and they can't do the things they want to be able to do. So it's all on a spectrum. Um, but ultimately, we don't want you to suffer. So if you're not able to do the things that you want to be able to do, then it's time to have the discussion. Um, a knee arthroscopy or a knee scope is an option. Basically, it's a house cleaning. You can get little dings in the cartilage. You can get little tears in the meniscus. You get little the meniscus gets frayed over time. Then you can go in there and kind of trim it up, or if you're able to repair it, if it's a big tear in the meniscus, then sometimes you can go in there and put a little suture in it and repair it. But this requires minimal arthritis and greater than 2 millimeters of joint space. So sometimes people will come to me with an MRI and it'll say degenerative medial meniscus tear, which we will see very commonly. That does not mean that you need a knee scope. You have to kind of evaluate what was the injury, what are the symptoms, is there arthritis in other compartments? Because if you got an MRI of every patient over 50 of their knee, I would say more than 50% of people would have a degenerative medial meniscus tear. That doesn't always mean that you need to have a knee scope or a knee surgery. Knee arthroplasty. So this is where this would be the cure or the treatment for arthritis of your knee. There are different options. There are things called a unicompartmental knee arthroplasty or a total knee arthroplasty. A uni, which I will show on the next slide, is basically if you just have arthritis isolated to one compartment, which is either the inside of the knee, the outside of the knee, or underneath the kneecap. So the knee is broken down in those 3 compartments. If you have it in just one compartment and the other two look pretty good, then we could consider just doing a partial knee replacement or a uni knee arthroplasty. If the arthritis has progressed to all three compartments or two or more, then you're talking about a total knee arthroplasty. And it's kind of a misnomer calling it a total knee arthroplasty. A lot of patients think like you're just taking your knee out and replacing it. It's really not. It's more of a resurfacing. So I'll show some images of that to kind of clarify that for you. In this procedure, it gets rid of the arthritis. It is impossible to get knee arthritis after having a knee replacement. Usually nowadays it's same day surgery. So you come in the morning, you have your surgery, you go to the postoperative PACU recovery area, and therapy works with you, and then you go home the same day. And you're up and walking right away. As soon as the medications wear off, we get you up and walking with therapy. And really, there's no restrictions. With knees, we want you to start moving it right away because stiffness can be a problem if you don't get up and move it. And now, with the implants today, there was worry, that doing knee arthroplasties in younger patients, they would wear out in the past. Now, implants are lasting 20 to 30 years, and typically it's the little plastic piece that we put in there that wears out. So it's kind of like a little gasket. If that does wear out, you can go in there, kind of and just exchange that gasket. So, like I discussed, a uni compartment knee arthroplasty. This is when arthritis is isolated to one compartment. So looking at the x-rays on the right, you can see on the inside of the knee there, the femur bone is touching the tibia bone. There is no space in between there. And if you look on the outside of the knee where the fibula is, where that skinny bone is, there's nice black space in between the femur bone and the tibia bone. So it looks like the arthritis is really isolated just to that inside compartment. In order to qualify for this, there's a few things. It has to be, you have to have an intact ACL. So that's something that we evaluate in the office with radiographs and also a physical exam. And the benefit of this procedure is it's a little quicker, it's less invasive, the recovery is quicker because it's less invasive, so not as much surgery. There's less pain, has great long-term outcomes. When I do this procedure, I do use a robot to kind of help me balance the knee and make sure that the implants are kind of positioned correctly. The big negative for this procedure is there's a risk of progression in arthritis in the other compartments. So you can progress to arthritis in the outside compartment or the compartment underneath the kneecap. Um, and then looking at that picture on the left there, that's kind of what the implant looks like. So you can see that the metal femur has been resurfaced, and then the tibia has a little base plate on it with a little plastic piece in between, and you don't touch the outside compartment or you don't touch the kneecap compartment. And then ultimately, if you have arthritis in two or more compartments, typically you're talking about a total knee replacement. So this would be, the tri-compartmental arthritis or three compartments. This resurfaces both the tibia, the femur, and the patella. So on the left, the x-rays show that you have bone-on-bone arthritis on the inside of the knee, but you got some bone spurs on the outside, you got some bone spurs on the patella. This would be somebody that would most likely benefit from, a total knee arthroplasty. And what that does here is you can see you basically shave off the arthritis on the femur and on the tibia. You put a metal cap on the femur, you put a little metal base plate on the tibia, and then you put a piece of plastic in between. And then underneath the kneecap, you kind of shave off the arthritis on the back of the kneecap and put a little plastic button on there. So you now it's an artificial joint, but now there's no way of getting arthritis after this. And then these are the typical, what the implants look like. That's that little plastic piece in the middle that goes in, and that becomes your new joint. So, just kind of a review. Typical order of treatment: start with non-pharmacological modalities, so weight loss, physical therapy, exercise, some bracing possibly. Medication-wise, try Tylenol. Doesn't work for everybody, so then you can try an NSAID like the Advil, Aleve, Motrin. Try, and then ultimately prescription-wise, you can try like a Mobic or something like that. Injections: start with corticosteroid injection. Decrease that inflammation. You can get that every 3 months. If that's not working as well anymore, or you're seeing less pain relief from it, you can try a visco or a gel injection, possibly PRP as well. And then ultimately, if you failed all these non-operative managements, you talk about having surgery, whether that be the uni or the partial knee replacement or a total knee replacement, and hopefully get you back to golf or pickleball or whatever it is that you want to do. And That's all I have on knee arthritis. So thank you very much. And these are just my wife and kids here. Glad to be back in Ohio. So thank you for having me.
Thank you, Dr. Goubeaux. We do have some questions. The
Okay.
first question is, I have had exams which show good space between the knee bones, but my arthritis is painful and I get stiff when sitting. Steps and inclines are tough and painful. I have had cortisone injections and another injection, which I forget the name of, but neither worked for me for longer than a few days. Not sure what I should do next.
Okay. Um, I would say I don't know if you've had an MRI or not. I would see if you have good space, on X-ray, like I said, you can't see the cartilage or you can't see the meniscus or the shock absorbers. But if you've had, the injections and all the non-operative treatment, and you still have good space where the bones aren't touching, usually an MRI is the next step, and see if is there a tear in the meniscus, is there some dinging of the cartilage, to kind of further, that gives us a little better picture of the soft tissues to evaluate. So maybe there is a meniscus tear and you need a knee arthroscopy or a scope to go in there and kind of just trim it up a little bit.
Thank you. Our next question is, will arthritis go away without surgery?
No, it will not. Arthritis, unfortunately, is a progressive degenerative process, so it will continue to progress. I don't have a way of predicting how fast it will progress, and when, how painful it will be. But there is no current way to stop arthritis from getting worse right now.
Is there a relation between knee arthritis and diabetes?
Um, no, there is not that I'm aware of. Um, Diabetes can cause there is a certain thing that you can get with diabetes called a Charcot joint. Um, this typically, though, it typically affects shoulders and feet, like your midfoot. It can, in rare occasions, affect your knee. I have seen that very rarely, but there's not a strong correlation between diabetes and getting knee arthritis.
Is the only option for bone-on-bone arthritis surgery?
I would say if you've failed non-operative management, then yes, surgery would cure the arthritis or get rid of the arthritis. But like I said, you don't ever have to have surgery. You can have bone-on-bone arthritis and live with it your whole life. The I guess the nice thing about arthritis is it's not cancer or a heart attack. It's not something that you need to do something about. If you can live with it and manage the symptoms, then you don't ever have to have a surgery. So you can be bone on bone and never have a knee replacement in your life.
Can I choose between a unicompartmental and a total knee replacement?
Um, I would so people if people are a candidate for a uni compartment knee replacement, I will offer that to patients. But there are certain radiographic and physical exam requirements that studies have shown patients do better with for a uni. So if you come in and you have arthritis in all three compartments, I would not offer you a partial knee replacement, because it would not address the whole problem. We would be, fixing a third of the problem. So, but if I can do a partial knee replacement on somebody, I will jump to that first, because I do think patients like those a little better because it feels more natural, and they recover a little quicker. So I love them, and I would definitely offer them to somebody if they're a candidate for it.
Next question is, I was diagnosed with arthritis and after no relief after an injection, an MRI showed a meniscus tear and a Baker's cyst. I have been to PT and I can move better, but is still having trouble bending my knee going downstairs. Can anything else be done for this cyst?
Yes, so we get that question a lot. And Baker cysts are very common on MRIs. A Baker cyst is a result of a meniscus tear. So if you have a meniscus tear, what happens is your body creates synovial fluid, all the fluid in your knee to kind of help lubricate the joint. It creates excess of that, and there's an area in the back of your knee in the joint capsule that is a little softer, and that when you get a buildup of this fluid, it kind of creates a one-way valve and it pooches out and causes this Baker cyst in the back of your knee. So a Baker cyst is a consequence of having a meniscus tear. So if you get rid of the meniscus tear, that typically gets rid of the Baker cyst. I have heard of people going in and aspirating Baker cysts and stuff like that. I would not recommend that. There is a lot of big structures back there in the form of vessels and nerves that you don't want to be around. And just by aspirating it, you're not getting rid of the root cause or the root problem. The meniscus tear is the root problem. So if you address that, then that gets rid of the cyst.
Would you recommend Pilates for knee arthritis?
I think it's yeah, it's great. I think it's just great for overall well-being, just being able to stretch and being limber. It's not high impact usually, so yeah, I think it would be a great option.
You mentioned stem cell treatments, but seem to dismiss it as not proven. I talked to a friend that claims to have gotten great benefits from stem cell approach. Can you comment any more on this option?
Yes, so it is a hot topic now. I There are people that do feel like they've gotten good relief from it, and you'll hear athletes going overseas or going to somebody to get it. Um, I like science to make sense, and I like an answer and to know why I'm treating it and what I'm using to treat. And right now, I just don't know that the research and the studies have proven that it is a good option. And I feel that it's an expensive option because the typical payment, the average nationally is $900 an injection. So, I mean, if you have the money in your pocket to be able to pay for that, then I think and you want to try it. That's your choice. I feel a little guilty taking patients' money, not knowing that it's going to actually help them with their pain relief. I think the cortisone injections and even the gel injections are a little more predictable and reproducible than the PRP or stem cell injections. But I'm open to it in the future if they come to a consensus that it actually does help.
Dr. Gitten specifically recommended I avoid injections. Do they deteriorate your bones or cartilage muscle?
So, if you get too many of them too frequently, they can cause a negative effect. But that's why we say that you can only get them every 3 months. And some of those studies were a little older and they were on like football players that were getting injections frequently just to be able to play in games and they were younger. But getting an injection, a cortisone injection every 3 to 4 months, I don't think is deleterious at all. I think it's a good option to help um, to manage your symptoms to try to help you avoid surgery.
What are your thoughts on BPC-157?
BPD. To be honest, I don't know what that is. Um, I guess if you want to take that patient's information, I can look into it and I can email them with an answer. I can do some research on it.
Okay. The next question is, if you take Tylenol or NSAIDs, can you take it once in a while or just every few days to get some benefit, or do you need to take it every day to get the benefits?
So Tylenol and ibuprofen, you can take those as needed. The prescription ones that are more like Mobic or Celebrex or Naproxen, typically those take a little while to build up in your system, about 2 weeks or so. So those ones I do recommend patients take on a more consistent basis, um, just to kind of help build it up in your system and see, is it helping you? You can take them as needed. They're just not as effective if you're not taking them kind of routinely. And the Mobic, it's once a day, which is the one that I typically start with, which is nice. So you can either, some people take it in the morning with their breakfast to help them get through the day. Some people take it at night with dinner to help them sleep at night. It's really up to you how you want to take it. But it's a once a day pill, so it's nice. It's not, 3 times a day or anything like that.
I noticed with the unipartial knee replacement, you said that the ACL needed to be intact. Is it the same with a total? Does the ACL, previously reconstructive, have any bearing on the total?
No. Um, the for a total knee, we get rid of the ACL. Um, it does not help function with a total knee replacement. So if you've had a previous ACL reconstruction, that has no effect. Um, we do keep all the other ligaments in the knee, the PCL and the inside and the outside ligaments, or the MCL and LCL. So those all stay, but the ACL does not add any benefit for a total knee replacement.
I have stiffness in my knee when I stand up after sitting. What color is the fluid that is taken off your knee supposed to be?
It's typically like a clearish yellow. That's the typical what synovial fluid looks like. It's a little thicker too. It's almost like motor oil, but like a clear yellow.
What is the difference between thinning of the cartilage and arthritis?
So arthritis is really it's a spectrum of a disease process. So thinning of the cartilage, the way we kind of describe arthritis with the image I showed in the beginning, where you had kind of all the knees and the progression of the arthritis, it starts with just a thinning, or we call it a fissuring, where you get little micro cracks in the cartilage, and then over time it kind of progresses to where that cartilage starts to wear away. It's no longer smooth, and then that's when it eventually gets down to completely wearing away to where the bone is exposed.
Is quadriceps enthesophyte something that is progressive and will require surgery?
No, typically not. What that is so when you have it's a little bone spur like at the top of your kneecap, and what happens is you get like quadriceps tendonitis, where your quad muscle, your thigh muscle inserts on your kneecap, and it you get this traction of it, and if you are doing a lot of exercising or a lot of leg exercises, a lot of running, and you're stressing that quad pulling on the kneecap, you'll get little micro tears in it. And then your body's mechanism to kind of repair that is to deposit a little bit of calcium or bone. Um, and that's when you get that little enthesophyte that usually is not anything that needs to be done with. It's just kind of symptom management, a lot of physical therapy, working on stretching to kind of help stretch the tendon from pulling so much traction on the kneecap.
Do you see patients that experience more pain after losing a significant amount of weight?
Yeah, I guess, yeah, I mean, it depends on what the reason is. But any weight loss is beneficial for your overall health, and two, for your joint health. Whether you're trying to manage your symptoms conservatively, or you've failed conservative management and are looking for a surgical option.
Can anesthesia be limited during surgery? And is the procedure done on site at ortho?
Yes. So the typical way that a knee replacement would be done with a spinal anesthetic. So you really don't get put fully to sleep. It's more of a twilight sleep. So it just numbs your legs so that you don't feel anything. And then we just kind of give you some medication to make you a little sleepy so that you don't remember anything or hear anything, and just kind of take a little nap during surgery. And then that spinal wears off. And that's how we get you up and moving right away in the PACU area. So we really do try to keep it, to a minimum, for your safety. And yes, we do currently, we do have surgery centers around town in Pickerington, Polaris, New Albany. Those are the typical ones where we do them same day. You actually can't stay overnight if it's at a surgery center, and that's typically where we do the surgeries. But for sicker patients or patients that need a little more help, we do the surgeries at hospitals as well, where you can stay overnight. But some insurances are moving away. Actually, Medicare and Medicaid now has labeled knee and hip arthroplasty an outpatient procedure. So they will sometimes not pay for you to stay overnight, depending on certain situations. So it is we are a push to kind of get you in and get you home, get you back into your environment and where you feel comfortable and safe.
I had chronic dislocated kneecaps, which were treated by bilateral release. Then I fell and broke my kneecap. I have used Uflexa, which gives me fairly long-term relief, but my new hip is causing me more knee pain. Arthroscopy, anything?
Um, that would depend. If you've had chronic dislocating kneecaps and then fractured it, my guess is your patellofemoral joint or your kneecap where it kind of rises up over your femur. I bet that joint is pretty damaged and has seen a lot of wear and tear. Um, you may not have arthritis in the other parts of your knee. There is, I didn't put it in this talk, but I only talked about the medial partial knee replacement. Um, there is a procedure where you can do a partial knee replacement on the outside of the knee only, or you can do one for underneath the kneecap where you just basically replace and put that little button on the kneecap and replace the little groove. That's a different form of a partial knee replacement, not as common, but it is an option. So, I mean, I'd be willing to see you in the office and kind of get some x-rays and evaluate and see what would be an option for you.
I have arthritis around my kneecap and I've lost weight and kept it off until I was diagnosed with breast cancer in 2024. Unfortunately, I gained 70 pounds from the steroids, and it's taking longer to get the weight off since I finished chemotherapy. Do you recommend acupuncture?
I think it's an option. Anything that's not invasive, that is safe, I think it's worth a try. It can't hurt to try something one time. So, you know, anything you can do to kind of help manage the symptoms. And I'm sorry for your situation. The steroids, those are a um, tough medication to take, sometimes necessary, but they do have their adverse effects when taken, systemically. So, yeah, I think anything that is not invasive and safe is definitely a good option.
What is the recovery process after a total knee replacement? What causes pain and stiffness when the replacement is over a year ago?
Recovery process. So typically, my saying is it's rules of twos. Um, you come in 2 hours before surgery. Surgery is 2 hours. You're up and walking 2 hours later, and then we get you home in 2 hours. And then at 2 weeks, knee replacements are a little more painful. They can take a little time to recover from. So the first 2 weeks are maybe a little miserable. They're painful. You're doing a lot of therapy to try to get the range of motion because that's the biggest thing. Infection and range of motion are complications that we dread with knee replacements. So we want you moving it and working hard at it. And then usually about 2 months, you're feeling a lot better and you're kind of more happy that you did the surgery and kind of weaning off the walker, the cane, and kind of getting your groove back. But any replacement, just like anything in life, a new house, a new car, anything like that, it takes about a year to get used to, and kind of this is kind of the way your new life is. So usually, you can have a full recovery up to 1, 2, or 12 months, a year out from a knee replacement, but usually about the 2 month mark is where people will really start feeling better. Stiffness after a year after surgery, that can be unfortunately a multitude of different things. Um, the biggest one is we call it arthrofibrosis. Basically, your body just creates an inflammatory response and you get a lot of scar tissue in the knee. That's why we want you, after surgery, moving it as quickly as possible and as much as possible to keep that range of motion because as soon as you get stiff, it is very hard to get that motion back.
Can you talk about hardware fixation versus cementing and expected results, longevity, stability, etc.?
Okay. I think probably alluding to press fit versus cemented knee arthroplasty. So the tried and true traditional method for knee arthroplasty has been cemented, where you use a cement to basically polymerize and bond from the components into your bone and kind of interdigitates into the bone and gets a good fixation. That has been the tried and true method. Over the last decade or so, press fit design has become more popular. It was more popularized in Europe, and now longer term data, 5 to 10 years, is coming out now in the United States. So this is where basically you do not use cement, and there's a porous coating on the implants, and that porous coating comes in contact with your bone, and over 6 to 8 weeks, your bone grows into the porous coating and gets its fixation that way. Um, I think there are certain patients, if you do not have good bone quality, specifically women over 65 is the kind of what the data is showing. They should probably have a cemented total knee. But younger, healthier patients with good bone, press fit knees are doing great. There's been showing no difference in outcomes at long-term studies. Um, there are benefits to it, but certain patient populations probably should still have cemented total knees.
Can you comment on the negative side effects associated with NSAIDs and approximately how long does it take to be considered long-term use?
Potential negative side effects. The big ones are, does it, do you get GI upset or does it affect your kidneys or liver? So those are things that if you have those risk factors in the past, I would maybe shy away from them or use them sparingly. Um, Long-term use, I would say, I don't know that there's a great definition for long-term use. But if you're using it consistently for, I would say 2 to 3 weeks, um, and then you're having symptoms, I would definitely back off on those because they can cause other negative side effects that we definitely don't want to go down that path.
14 months after a total knee replacement, will numbness still exist and will there be difficulty or pain to put weight on or kneel on that knee?
So numbness depends where you're having it. You almost everybody does have a little bit of numbness on the outside of their knee, on the outside of the incision. That's because the nerves that supply that sensation run from the inside of your knee across the knee to the outside. Unfortunately, there's very small sensory nerves that you really can't do anything about. So that is something that people will almost always they can regenerate and grow back, but nerves are a little finicky, so they do not always kind of regenerate and get that sensation back. And kneeling on a total knee replacement can be painful. That is one thing that patients don't like to do after a knee replacement. um, Multitude of different reasons as to why we think that is. Whether it's just you have an artificial knee, it's painful with the kneecap because you have a prosthesis on there. Is the incision? Is it kneeling on the incision? We don't have a great answer for why, but specifically, like if you're a carpet layer or somebody that has to be on their knees a lot, typically they don't. It does not feel good to do that.
Are you supposed to avoid running or explosive movements after a full knee or hip replacement surgery? Is it possible to be a competitive athlete after said surgery?
That's a good question. That is kind of a topic of debate now in our world. Should you be limiting patients on what they want to do? Um, I'm of the mindset that we want you to live your life and do what you want to do. Um, so I hesitate restricting people because the reason I do a knee replacement is to get you back to doing what you want to be able to do. I don't want to put restrictions on you. So I it you may there's no great study showing this, but maybe you do if doing a lot of running, it may wear out the plastic piece or the little gasket that goes in there. It may wear it out a little quicker. I can't say for sure, but I would say I want you to get back to doing what you want to be able to do. I mean, maybe not running marathons. That's a little much, but going for a jog every once in a while, I don't think that that's a big problem.
If both knees are compromised, how quickly after the first can the second be done?
Typically, 31 days after the first one. Um, it depends how motivated you are and how much you want to push through it. But typically 31 days after the first one is when you can do the second one. Some people will do it then. Some people will wait 3 months until they kind of recover a little more from the first one and then do it then. But 31 days is usually when I'll do the second one.
I have significant limb length disparity in right and left femur, resulting in left trochanter OA and pain in right lateral knee OA pain. Trying to level out with insoles and built up shoe made opposite side pain worse. Are all replacement parts the same thickness?
That depends. No, there is some modularity or some, you know, kind of customization that you can do. The plastic piece that you put in can be a different size from anywhere from 5 millimeters to 20 millimeters. There's it depending if you've had a hip replacement. That's one place where you can see some leg length discrepancies because there is a lot more modularity with that and how you can kind of lengthen somebody or shorten somebody or give them a little too much offset or kind of make their hip a little more lateral than what we'd expect, and that then you can see some of that bursitis. So there's a multitude of different things that could be causing that. I would say no, not all implants are the exact same. There's some modularity or customization to them.
And this is our final question for the evening.
Mhm.
I have a knee that continues to buckle. Is that from arthritis or something else? There are days with discomfort. I the There are days with the discomfort I will put on my knee brace. I had injections before, but it did not relieve the pain I have.
I would say if it's not from a knee replacement buckling, but if it's from your native knee that you were born with, the buckling is usually it can be from arthritis because it's painful and it kind of your knee just gives way on you, or it can be from a meniscus tear. When you have that shock absorber and you get a tear in it, it does have secondary stabilizing factors, that shock absorber. So if there's a tear in it, you kind of, put a little wrench in the system, and that secondary stabilizing mechanism with certain activities, usually it's twisting or kind of incline activities, that can it can shift on you and it feels like your knee's going to buckle. So that is something that could be causing those types of symptoms.
Thank you, Dr. Goubeaux, and
All
thank you
right.
for participating in tonight's webinar. Our next webinar will be held on September 9th. Dr. Brian Skura, OrthoNeuro's new sports medicine surgeon, will speak on hip impingement and hip arthroscopy. Enjoy the rest of your evening and good night.
Thank you for having me and thank you all for joining.